It is my pleasure to welcome Dr. Niels Kudzik, a professor of cardiology and the head of structural heart interventions in the Aarhus University Hospital in Denmark. Thank you so much for joining us, Dr. Niels Kudzik.
Thank you. It's a pleasure for me to be here with this interview. Thank you.
Today we'll discuss your state-of-the-art review on device-related thrombus, or DRT, after left atrial appendage occlusion. The way I want to start is start with the basics. Can you tell us about the incidence and timing of DRT after left atrial appendage occlusion?
Yeah, device-related thrombosis is something that can happen after implantation of a LAC device, and we see that in 2 to 4% of cases within the first year. And the majority of cases is early within the first months after implantation, but unfortunately, we also see late cases. So actually, up to about 50% of cases may occur later on at about 1 year after. So it's a little bit unpredictable. We believe that endothelial coverage is something that will prevent DRT, and I guess that there's a huge variation in installation of those devices. That's probably the explanation for the variation in the time window for DRT, I think.
Okay. And, given that variation and that risk, are we able to predict, the patients who are higher risk to develop the DRT, or to kind of monitor them more frequently than other patients?
Yeah, I think we have learned quite a lot about risk factors for DRT. There are patient-specific factors like high age, female gender, a very high JACC score, prior stroke, reduced left ventricular function, coagulation disorders, renal disease. That is some of the patient-specific factors, but there are also device-specific factors like having a deep implant of the device. But I think as a common feature for the risk is it's about having very slow and low flow at the surface of the device. And that's also why we are trying also to do computational flow dynamic measurements actually to look at what's going on near to the device. Do we have very low flow velocities? That will also be a patient that will have a high risk for DRT. So yes, we are definitely learning about those risk factors.
Thank you. And kind of for the people who develop DRT, and can we grade the severity of DRT, or any kind of high risk population within, or everyone is about the same in terms of risk?
Yeah, I mean, due to this adverse event from LA implantation with DRT, but also with leaks, it is really needed that we do some post-procedural surveillance, and we do that. And current standard here is still mostly transesophageal echo, but more and more we are using cardiac CT. And there has been a number of studies to suggest that CT is, maybe even better than transesophageal echo to evaluate leaks and evaluate DRT. And it's also much more comfortable for the patient to go through a CT instead of a TE. Then we have tried to develop and describe a classification for DRT as seen on cardiac CT. What you actually can see with CT is hyper-attenuated thickening. So you can see a thickening, contrast filling space. Typically, you see this thickening on the device surface. And this can be innocent, like, for instance, with the Watchman Flex device. You can see underneath the membrane of this, we call that grade 0 hat. That is something happening intradevicely, but we can also see layerings on the device, outer device surface, or the atrial surface of the device, That can be a smooth, thin layering, less than 3 millimeters. We call that grade 1. It's a sessile layering lower than 3 millimeters. Typically, you see that there are also continuation to the LA wall. But if we have layerings or had changes that are more than 3 millimeters, especially if they are irregular in the surface or if they do not continue onto the LA wall, that is something that we consider more risky and with a high likelihood of representing DRT. And if we actually have pedunculated changes, that is something we really see as DRT. So grade 2 and grade 3 classification for CT, that is a high likelihood of DRT and will typically make an indication for treatment of DRT. So I hope this classification, it can be used both for monocomponent devices, but also like dual component devices like the amulet. And in many ways, there's also similar or corresponding changes actually to look at with TE. So I hope that we can agree in the future also for future studies on using this classification.
Yeah, thank you. And kind of, you touched base on, the high risk and the indication to treatment. How do we treat these patients? Is there a consensus, international consensus, on how we treat these patients with DRT? And kind of, can you tell us more about that?
Yeah, I think we have learned that it is actually, if you have a DRT, it's necessary to resume all anticoagulation.
Okay.
And it can be maybe like you can resume with warfarin, or you can resume with DOAC, and in some instances or some centers will prefer low molecular weight heparin. But it is necessary to resume anticoagulation to get resolution of the changes. And it's also our experience that if you stop after having a resolution, if you stop all anticoagulation, there will be a risk, a considerable risk again, that we will see development again of DRT. So in many cases, it will be actually more prolonged anticoagulation treatment. And we have one other study that are looking at this, actually published in the same issue of JACC Intelligence, looking at actually the size of the DRT, the mass, the size of the mass is a very important factor in if you get recurrent DRT again after stopping all anticoagulation.
Okay.
It's problematic because, I mean, a lot of our patients having LAA occlusion, they are prone to having bleeds and a high risk of bleeding. So,
yeah, it's a tricky population, and there's I feel like there's still we have learned so much from your expertise, and everyone's expertise in this field is so much for us to do more in the field. But thank you again so much for your time, for sharing your expertise, and congratulations again on your state-of-the-art review.
Thank you very much, and thank you
you
for
so
your
much.
time.